years and very illustrious person with a very long and commendable career. He would introduce himself to us. So, Dr. Malakar, I request you to kindly come over and take the dais. Thank you. Good afternoon. Can you hear me? Yes? Yeah. I can't hear you. This is a great pleasure for me to be here, especially Dr. Mukherjee, who invited me to come and join you. And I am overjoyed to be with such a great group today. আমার নাম হচ্ছে কমল মালাকার। আমি আর্জিকল মেডিকেল কলেজে পাশ করেছি। পাশ করে আমি ডক্টর অভিষেকের সাথে কাজ করেছি বছরকে অন ক্যান্সার সার্জারি at Chittaranjan Cancer Hospital and Chittaranjan National Cancer Center. With these, in 6 years I went to England and I did a PhD in cell biology from Imperial College. But I never wanted to be a laboratory man. Came back to clinics and then I did my clinical oncology training in Oxford and in London Hammersmith Hospital. So then in 1976 we had a problem with opioid, if you remember. 1976 and all. And so they were all intellectuals are living in England. So I went to Canada. And there in Manitoba I stayed for nearly 17 years and eventually became the department director, chairman of all stupid things. And then my foot started to itch. What do I do? What do I do? Somehow I got a call from the chairman of radiation oncology at Harvard. Because I had interest in radiation protection. He said, oh, I'm a radiation sensitive man. You are a radiation protection, why not done up? So I went there for 1 year as visiting professor. Instead, I stayed there for 6 years. And there I wrote my book called Radio Protectors India. And then after 6 years, I went to NIH for 3 months, and then I took a year with a call from the college that I had. And I was there, I established 2 radiation oncology center practice. The good thing I did, I was able to organize this radiation oncology clinical research program that we did. Then I came to NIH again for 2 years. I went back to Saudi Arabia for 5 years. I was established cancer surgeon. Came back. Then I had to go to study biology. I did not know where I fit in. So eventually I got a call from the Ross University Medical School to go there as a professor of internal medicine. I take it, but I established oncology. এখানে কোনো মেডিকেল কলেজ I don't know that oncology as a curriculum I told me. So we established the oncology for undergraduate curriculum for Ross, and then it just goes on. And then one thing happens that the university is very poor to helping, and the university I was working, they were actually very badly damaged, and that was shit from here and there. Then coronavirus started, and in the meantime I had already taken a job in Singapore. I started for 6 months and then came back home, and I never went anywhere for 3 years. I stayed there. And that was a life-changing situation for me. Because of my time, I was able to devote for thoughts and thinking, and I was able to publish quite a few non-medical and non-fiction books, and they're all available. Now, I don't not while he was a student, but I did it many, many times in the National Cancer Council, WCC. And last time I met him in Kuala Lumpur, I think in 2018. And then so I do cherish my interaction and friendship with him, and I thought that I must be acquainted with what he accomplished. It's a great thing. And today, thanks very much for Dr. Mrs. Mukherjee for asking me to come. And the topic I'm going to be talking about, innovative recycling of science, technology, and practice of cancer management. I changed the recycling word. Recycling comes with garbage or plastic. No, the new what I recently repurposing. That's more science, more similar. So, innovative repurposing of science, technology, practice of cancer management. And the other would say, am I speaking too fast? So, the problem is now the skyrocketing, the cancer treatment is becoming unbearable, intolerable, and it's impossible to comprehend how fast it's going. In every country, everywhere, whether it's the United States or in the United even governments are really feel the pinch of the estimated cost of cancer treatment. So that is one of my objectives, how we can really reduce the cost of cancer treatment. Cost of cancer treatment by not changing the whole system, but repurposing the whole system. That's the whole idea. You all know about this insurance business, and the world diagnosis of cancer was diagnosed in 14.1 million, but is expected to be 23 million by 2030. And the picture tells you, one picture tells you more than 1,000 words. It tells you what's actually happening to various age groups, how the incidence of cancer is increasing. So the most vulnerable are the elderly, between from 65 and from 70 onwards. This certainly happening in Goris, that cancer is actually increasing steadily. And actually it is steadily. The United States are then it doesn't matter, it is increasing. That is the reason, that out of my passion, what's happening, the reason is, yesterday I was talking to you about the epigenetic contribution for cancer. The epigenetics is actually the main thing why the cancer is getting so far. That is the environmental contamination. This is a very interesting picture to see. Let's focus on one, very how it is increasing. Pointed to. I just want to see the dynamics of the this visualization dynamic picture, you can see the changes in the color for every year from 2001 to 1917. And Canada, it actually was like this in 2091. And by this time, 17, the color changed to blue. And it's happening everywhere. Unfortunately, India and China has changed. They are the highest number of cancer patients. The highest number of cancer patients right from the time when the statistics were taken. Let me see if I can read them. Okay, anyway, so this is just another picture showing you what is the proportion of people share the cancer diagnosis in India. And here you can see what is happening from 1990 to 2017 on the incidence of various cancers. 150 billion has already surpassed 150, now it's 165 billion. That was in 2020. This is continue to increase by 7 to 10% every year. The 60%, the interesting is the 60% of cancer occurs in the low socioeconomic countries. However, 5% of the global spending is directed to these countries. The real cost of cancer is because of affected organs, stage of cancer being detected, kind and brand of medicine we choose, number of chemotherapy cycles, all these things we know. I don't read about this, you know. So I go back. What's happening on monetary terms? It costs about 8,000 to 80,000 USD for a scan of breast cancer. And you can get to treat this patient. And now what's happening also the prices, oncology, the drug prices is still increasing. I don't have to show you, this is picture tells the story. It is increasing. It is increasing now, only not stabilized, but on mountains. And we are using very expensive drugs. The expensive drugs that we're using because presumably we are led to believe that more money is spent, better treatment is, which is not always true. But we don't believe that. Anyway, so that's exactly what's happening. In all these immunotherapy drugs, I'm sure that they are doing their job, but we cannot really justify the costs. No, we just cost analysis. Why? What is the cost? Thank you. And let's go straight to the prices of the hardware. Linear accelerator costs 4 to 4.5 million. Telecover is 840. The government in India they have reduced to 750 now for us. The kilo voltage is 250 to 300,000. Brachytherapy is about 300,000, and CT simulator, which is an integral part of modern radiation oncology treatment, is 350. It's coming down again, but it's still in that region. Treatment planning system is $250 million. So it's very expensive business, very, very expensive. Built the facility for radiation oncology facilities. The linear accelerator, a bunk that costs 2 to 3 million USD. I'm talking about what happens in my country in Canada. Bunkers for Telecover unit is for 1.5 to 2 million. Housing per kilovolt is quite high. Imaging planning is 1 million, and brachytherapy housing is $500,000 USD. So again, just to prepare for the treatment is not cheap. It's also expensive. So even increasing complex and expensive technology, increasing costs of chemotherapy and other systemic treatments, increasing costs of managing side effects of newer agents. These are all standard factors. I'm just speaking to know why the cost is increasing. Now, what's the trend of modern cancer treatment? This is about 4 years old, but still very much old. So, cancer practice tend to treatment either when you use the same environment, the single agent like radiotherapy or surgery or single drug. Single modality in combinations like CME. multiple modalities like single agent, radiotherapy, hormones, and sometimes radiotherapy and chemotherapy, and multiple modalities which includes combination therapy, surgery, radiation, and surgical chemotherapy. This is all data with some people were started with. How do we give them sequential? Application of multiple single agent like CME, concurrent application of multiple agents like radiotherapy assist and neoadjuvant and adjuvant setting is also delivered. Surgery can be used for primary cure. Many cancers are really can be cured by only surgery if the cancer at stage 1 or early cases. And surgery plus concurrent chemotherapy, surgery plus radiation treatment, and hormone. I can never get used to it. A bad horseman always blames the object, speaker always blames the mic. Sorry. So primary surgery, primary concurrent chemotherapy, surgery, radiation, hormone, surgery, adjuvant, and so on. Radiotherapy can be a primary treatment for cure, and can be curative, palliative, or can be adjuvant. Chemotherapy again can be primary for curative cancers. Adjuvant chemotherapy and palliative chemotherapy also be used. Now, chemotherapy is very, very complex. It takes at least 5 hours per day to explain what's going on, and then also 5 years old. And so many things are happening in between. In my mind, what we call immunotherapy for cancer is really not immunotherapy. It's something else. It's something else again. But eventually, they do get involved for the fund, but the pathway is very different. But still, it is immunotherapy, it does the job by immunoaugmentation to a different group. Anyway, so still it is a testing tool. In the past time, this ability we see before, role and efficiency has been still determined, we don't know what is done. Keytruda has actually won his reputation, but it is so expensive. Keytruda is also just not an immunotherapy agent, it is also antiviral. So that's why it works so better. So role and efficiency being still determined is a high toxicity level related to the place of in-cancer treatment protocols are still being assessed and determined. Complex toxicity interaction with other agents is poorly understood how they mix. We can do radiation, surgery, chemotherapy, all of them, but still we don't understand how the immunotherapy and radiation or immunotherapy and chemotherapy will be interact and whether it is good or bad. The complex toxic interaction and other agents are poorly understood, but scientifically it has a huge potential within the next 8 to 10 years to see the success. Scientists have a way to find out the right fluid. And the cost of cancer immunotherapy is prohibited. Why we cannot really use chemotherapy for everyone who deserves it, and the complex science is poorly understood. Still, it is really very poorly understood, not quite well. Unlike single agent immunotherapy, cancer immunotherapy has multiple steps to be continued with, and new steps will emerge as we focus on failure and toxicity. Here, okay. Long-term side effects are yet to be discovered and the process to be understood. So discover, however, we must not understand why is the reason. Why is the reason we cannot fix it. Counseling. There have been many tests, several tests experimental and with patient. It can be used as a chemosensitizer and radiosensitizer. It can augment the effect of hypothermia. First time I'm using the word hypothermia. That's what it's all about. Immunotherapy are the possibilities. With progress of science and understanding appropriate usage will emerge. As time goes by, we'll understand, we find the right place and the right hurdles to overcome. Effect of hypothermia enhances and vice versa. Both immunotherapy affect the hypothermia and hypothermia also affects the effect of immunotherapy. I have to tell you one story. My aunt had tuberculosis in late 40s. There was no PAS, no nothing. My dad is a doctor. He said, well, he actually treated him with small dosage of Corvax. And that induced hypertension, and she was well, she got cured. And she lived another 40 years after that. No, the effect is hyperthermia enhanced and vice versa. So that's what it is. They can work for each other. Hypothermia can be used as a single agent, not for cure, but as an agent. Hypothermia can be used as a single agent when they use it cauterization. It is possible to use hypothermia or heal for cure, cancer cure. Hypothermia concomitant with chemotherapy and immunotherapy is useful. Hypothermia concomitant with radiotherapy has shown to be useful, and it can be effective during perioperative radiation hypothermia before and after. It does improve the sensitivity, and also it does improve reduce the possibility of recurrence. It has lots and lots of references about it. The cost of hypothermia technology is very much low for India. You're happy to know that it is. How is given the executive now externally, external being reviewed with various applicators on different places. The one problem they had was hitting the skin. The skin used to get hot and blistered, but that solved the problem with circulating water and ice packs and all these things. But these are done mechanically. We don't interfere in the treatment. So the main problem of skin being heated, I'll show you one picture that it really is not an obstacle. But on the other hand, with this multiple applicators, it's possible to focus at a deep tumor. In a way, we are able to focus radiation, and we can actually add the effect of radiation and hypothermia at the same time. Now, biology is simple. When your finger or anything gets heated, what happens? It gets red. What does it mean? There is increased blood circulation. What does it mean? There is increased oxidation. What does it mean to the tumor? Means increased oxidation means there is increased cell segregation. With this increased cell segregation, both radiation and chemotherapy works better. It's just simple. It's high school stuff. That's what I think. Anyway, so that is the macro environment, that's what happens. And the micro environment, there is a whole lot of things. I can't go on, but I'll tell you what happens. The therapeutic enhancement of all the anti-immunogenic agents and physiological protection systems, immunoaugmented as an orchestrated agent, as a secondary support, which happens for hypothermia. And the subcellular interaction is more complex and more invasive, more pervasive, and more definite. And you can really mathematically calculate how much is going to be. And if you know the area, we know the treatment, we know the radiation, And of course, nowadays with ultrasound thing, you can really measure the blood circulation during the course of treatment. And that's being done sometimes. So microbiology includes blood supply, as I said, gives you oxygen, reduces hypoxia. Hypoxia is the biggest enemy for both chemotherapy and radiation. And it enhances radiation and chemosensitivity and higher tumor cell kill, as I mentioned. The microbiology of the subcellular level, what happens, it inhibits DNA repair after radiation and chemotherapy. Multiple metabolic events have lots of experimental work done. I must have been quite a bit on animals, how hypothermia can actually inhibit the repairs and go on damaging the tumor. Multiple metabolic effects of heat shock protein, as doctors were telling, it does have both beneficial and also deadly situation for tumor itself. And increased serotonin induction of enhanced apoptosis. It induces apoptosis. You know that when there is apoptosis, there is no further cell growth, the tumor is dead. And these are the after the radio chemoimmunosensitization and combating anemia for cancer treatment by increasing blood supply. So these are the various parameters how hypothermia works. And hypothermia works best between 39 and 45 degrees centigrade. And that can be controlled with the modern system. So what happens? The potent, there's various ways to how does it modulate tumor immune reactions and immunity, both body and human cell. There's various phases go through, and then how it's potentially including the sensitivity. Hypothermia has got whole lots of effect, and that all these tissue changes towards improving the therapeutic benefit. And here, I'm showing you this is how one can really focus on the hypothermia. We wanted 5.9 or 6 degrees centigrade there, or maybe higher. And this is a hypothermia dosimetry for cancer studies. Although you can see there is hot, but this is very temporary. It just goes away quickly because of the constant system they have. But I have not seen really any skin change, skin burn with the modern treatment. But when it was doing before, we had a problem. And these are the results. I told you that here is the J, and here you can see the cervical cancer, 57 and then 83 when you add hypothermia to it. 50, 64, 84. And there is no question that there is a therapeutic gain. And this has been shown by many countries, many centers, many places, and particularly in Japan and China. I think, again, the component response to cancer treatment radiation, only radiation has hypothermia and radiation, and this is quite obvious. You see that head and neck patient will do better, breast cancer will do better, lung, colorectal, they all do better when we apply hypothermia concurrent with a planned way to enhance the therapeutic care, in particular treatment modality. Let me show you the Japanese clinical. Anyway, hypothermic clinical advantage is that it can affect the surgical cure rate. It can make the radiotherapy and chemotherapy and immunotherapy all their therapeutic gain can be improved significantly if initiated properly. And then complete response of cancer treatment radiation versus hypothermia and radiotherapy, we saw that how it happened. Going back again. The role of classical cancer therapy and the scope for improvement is many. The essential component for cancer treatment, small tumors can be treated by radiation surgery, and we all know that. Although when the surgical cure is imminent, but still we can get 10 to 25% recurrence, global recurrence. But this can be significantly reduced with the total perioperative hyperthermia. But T3, T4, the results are better, but it cannot be controlled by only radiation, but it has to be in multi-agent treatment. Preoperative or neoadjuvant chemotherapy for both on both active on the cells. Actually, it does benefit or improves surgical outcome. So, preoperative and neoadjuvant radiotherapy helps. Radiotherapy and chemotherapy both helps for surgery. Selection of radiation fraction, chemotherapy dose, frequency, and multiple drugs and optimization improves control rate. The radiation fractionation is an important factor where we don't really give any care, any attention to that. After every fraction of radiation, the tumor has changed, it is not same. But you kept giving the same dosage, one after the other. The changes are very simple. Changes in vascularity, changes in oxygenation, changes in hydration, all those things are actually, they can cause impact on fraction. So now, after many years, people have started understanding this, and there are investigations going on to use different fractions during the course of treatment. I did this one long time ago. I had received the 121 patient lung cancer patient giving various fractionation during the course of treatment. And that is kind of how I really work. And now they're asking me to put it up in the papers. I've presented in many places, but I don't understand, but I do it. So essentially that, you know, the Cooter who started giving radiation, just one fraction, but why he fractionated it? Because the patient did not come. So the fractionation came in that way. But the fractionation, the same fraction given one after the other is okay, but it's not the optimal thing. Because the cancer, one of my physics friends, cancer tumor is not a brick or not a block of concrete. It is a biology, it changes. After every treatment, when the chemotherapy, the biology changes. So you must actually look at the biology, not physical state. So radiation fractionation we should start thinking about giving that different fractionation during the course of treatment, but that can be done, that can mathematically work out. And you can really measure, you can blood center, ultrasonic measurement thing. You're not a pro, you just need the ultrasound thing, you can see what is the blood supply, and then you give you the oxygen level, and that way you can mathematically work out what is the optimal time when you should do it. Maybe 120 today, tomorrow maybe 150, or the day after tomorrow maybe 250, depending on the state. So we have to. Yes, and that is for you. It sounds funny, but it is very, very true. But it's coming, it's going to come. There are two very large studies going on, one in Maryland, Oregon, and other one in Texas. So these people that understood that there is a role, so there must be something. And so that happened when I did my protocol went through the whole university ethics process, and they accepted it, and I did it. I did it for 9 years. I did 121 patients, and I was 71 or 75 evaluated cases. Now I don't evaluate. So the hyperstatic actually has used for the radiation to 25 to 40 daily treatment there is used, fixed fraction or say, fixed interfraction gap, 24 hours. 15 fractions. The need from those is controlled time. So again, in the target, there are various pockets of variable violence. So they don't all of them with the same amount of. So that is one beauty of or different of program. The program is dependent on the concentration. So if you really measure the dose deposited at present treatment, it is very bizarre. It is not what the beautiful sigma curve they show. It's not really that. But when you measure it, you see that there is lots of ups and downs, ups and downs. Here ups, there are downs, here ups, there are downs. But still, because of the oxygen reasons, it does better than ordinary radiation. So adjuvant chemotherapy, radiotherapy, and continuous chemoradiation are the buzzwords for us today, and we can gain, therapy can be done with this. So dynamic changes of fraction size, what we have been advocating, and hyperfractionation, advantage of circulating. Plus, you know, that giving radiation in the evening or night, it protects the gut much better than giving radiation in the morning. Is it good to you? I hope not. So, particularly in principal they did it, all the cancer cells where external radiation was given in the evening. And there was you can check it. But it is logically, logistically difficult, but the science is there. That the radiation effect can be dependent on. So there are many things one can do. But looking at the biology. So, multiple variable chemotherapy combinations. One, I was so surprised that one leukemia, I can't remember exactly, it is cured child leukemia. They use 18 different kinds of chemotherapy. After 18. Just not, we are used to 2, 3, 4, 5, but, and that is a series I saw in slow caring. So use of multiple chemotherapy agent can be justified, and it scientifically applied, and the results will be much better, cure is much better, at the same time the toxicity is less. That's what I'm trying to say. And then the actual hypothermia and other modalities has to be properly studied and incorporated. Chemotherapy is mostly intravenous. It's combination 2 to 4 drugs and is repeated every 3 to 6 weeks, generally 4 to 12 cycles. And this is what we all know. And it can be further enhanced by the diurnal sensitivity and continuous versus repeated bolus. There are a lot of studies done, but in continuous throughout the particular bilateral studies done. We know that continuous bolus can be better, can achieve better therapeutic gain than bolus treatment. That's because of reduction of toxicities. Now, then I'm going to give you an example. Now, so what happens when doing 6 cycles of AC? We get 60% of response. Medical obesity, anyway, we get 60% generally has maximum 60%, right? But toxicity is 100%. The maximum response does not increase. The response does not increase by increasing number of injections, but toxicity will certainly increase. Do the same cycle. But if you need more chemotherapy after recurrence, that's a different ballgame. But when, for the first time, if you are decided there's 6 cycles from practice, then there's 6 cycles, but the still disease just go on giving. move 5, 6, 7. It doesn't work. It doesn't work. Maybe apparently it might work, but the therapeutic game is not that great. But what I've been suggesting that is, which there are evidence I told you about that leukemia patient, when you instead of giving 6 cycles of AC, you can give 2 cycles of AC, 2 cycles of CME, and 2 cycles of TC, and all 6 cycles. That's what happens. 2 cycles of AC will give 50%, and then CME 40%, and then TC will 40%, but the combined effect will be 130% response rate. These are all worked out mathematically and statistically. And toxicity will be about 90% instead of being 130%. It's both because of different, because it's understandable, simple, because different drugs are targeting different sites. And the recovery rate is very different. I'll show you in a minute. So by using the different multiple cumulative, the gain could be anything between 144 to 44. So what happens here? When you give AC1, 3 ACs, you see that it is working on one side only. And when it recovers, the recovery is not complete. It can damage. I'm not talking about cancer, I'm talking about the normal tissue. So the toxicity is will be more. It will be lose on therapy gain. On the other hand, when you use different kinds of chemotherapy, there are 3 or 4 different types of areas to target them. And so you see that AC1, they will have less, although individual drugs are less cell kill, but when you combine them, the cell kill is much more. And also the toxicity will be less. So that is the thing we should be thinking doing. And by doing this, we can also reduce the cost of treatment very much. So suggested protocol is that we must stage the disease, tumor board for treatment, recommendation treatment, or whatever it is, the primary surgery, neoadjuvant chemotherapy, neoadjuvant chemoradiation, whatever it is, the suggestion, standard suggestion by the tumor board. But what we need to do is to find out the proposed protocol will be how do we gain by giving hypothermia by 1.2. And hypothermia can you give with standard treatment 1.4. And so advantage of doing all together with hypothermia can be anything between 1.8 to 2. It can be done. So this is an algorithm of the innovative recycling, and we propose we start with the radiation before with the hypothermia, and then for 1 hour before treatment with the chemotherapy radiation, and then treat them, and then only once every week. Twice every week is maybe better, but the gain is still assessing. But once every week before chemotherapy or radiation fraction is good enough to gain whatever our objective is. And then after that, you just can carry on with neoadjuvant chemotherapy or neoadjuvant, and then along with that, with this hypothermia. The hypothermia treatment continues with every intervention to enhance their therapeutic gain. And then eventually, we get the hypothermia surgery, hypothermia post-operative adjuvant radiation, post-operative concurrent chemotherapy, all those things are supplemented by hypothermia. And this is a nightmare for logistics from my radiation oncology background. But once you get used to it, it is any complex treatment. There is really no complexity once you know exactly where to go. So, but it is a bit of a logistic problem, but once you get used to it, it is not a problem. But they're pretty. So interest rates are provided on this This is the information thing that the covert treatment we talked about it. Hypothermia machine actually, it costs 1.2 million in the United States, but it may be less in this country. And particularly by my investigation, I think it has not been caught up in our age. So anybody who becomes the first pioneer will get a lot of funding or assistance from various sources. I mentioned to you. So I think the cost 1.2 million for hypertension is really, it is peanuts compared to proton, compared to 4.5 million of hydrogen. And the maintenance is very low, and the hazards are very low, and there is no real other problem than light specialists. I think that the radiation, chemotherapy, all this kind of stuff, and we adding the other things, there's the infrastructure area we need. And what the other things we need, oncologists, we need technologists, and then the nursing cases, all the stuffs, we know how to organize a radiation oncology setup. And also as mentioned, the salaries. These salaries are not Indian salaries, not American salaries. Does not hurt me. And so I have been actually promoting takeover for undeveloped countries because we now for covert machine, there is IMRT, ICRC, the heart, he has actually already, from Guy Hospital, there are lots of physical papers published by him, how to use covert beams for IMRT and ICRC. That way you can reduce the, not because a lot more beams, So it is possible, if not, exactly reproduce what a 670 or 8 MB, but certainly not very far. So covert can be used. So I am actually promoting, and its cost, covert maintenance is very low, and not very low, but it is nothing compared to 670 or 8 MB lunar structure. And the downtime is frequent for the accelerator, and it's short and minimum of covert. Working hours, 8 hours, but covert can be used for anything between 12 to 16 hours. Longevity is 10 years for lunar, and covert is 10 to 15 hours. So there's a lot of effort and trying to put it to the developing countries. Yes, covert is not used for a, and we use it for your advantage and can be much cheaper to organize. So if you, for facility, with 1200 square meter, for main accelerator, we need 1500 square meter, plus 300 square meter for the hyperthermal unit. So around, for covert about 1500, and for main accelerator about 1800. And this includes the space for radiotherapy unit, clinical concentration space and everything. Administration, reception, chemo administration, procedure planning, production, etc. So the reaction now is all it is over to what is, I don't want to repeat again for the time's sake. The cost is not a significant cost of working. If one wants to use takeover and use the program, use the hyperthermal in a way I showed it. And the logistics of operation requirement, I said that you can start from the ground. But to build a radiation oncology center, you need a land, building, equipment, staff, logistics, diagnostic, imaging operations, all you need. But if the land is given, the cost comes down. If the land is building is given, the cost comes further down. The land, using equipment and plants which are not given, like what we have here, it costs, we bought an extension for the habitat, cost comes down 60%. And then after five, if you have a functional on and just need to add some extra service to habitat unit and add stuff, again the cost comes significantly. So the ideal situation is to piggyback. Oh, sorry. Thank you. So the ideal situation is to what we have to piggyback the hospital unit, and it is only about 300 square meter maximum for the entire unit. So that's what all I have to say. I hope I manage to incentivize you to think about different way, and hopefully I still have a third unit as in this situation. Thanks very much. In case anybody has any questions, Dr. Malakar is here, you can ask. I don't think there is any questions from that side.
No, hyper machine is there.
But they're not manufactured in India. You can get one in US.
What is the company?
Company in Utah. But the agencies have a second, they sell all radiology. And the radiology, how they
Hyperthermia is FDA approved, but it has not translated into BFS and OS advantage.
the American.
No, I'm not telling about hyperthermia. I'm telling about the machine that gives hyperthermia.
Yeah.
Without machine, we cannot have hyperthermia.
There are about
Machine gets approved.
available 16 centers in the industry, but they're very in Japan, South Korea, and China. Okay, Dr. Malakar, thank you very much for your lecture. It was a very informative lecture, and on behalf of the hospital, I convey to you our deep thanks and gratitude. Thank you very much. Next, I would like to invite Dr. Samoy. Please come to the dais for the next lecture.
So, good afternoon. On Saturday afternoon, everybody must be a little sleepy and little thirsty. So my topic is very simple, complex core biopsy planning and technique. Every day, left and right, we are doing core biopsy. Let's just see how I can make this simple topic a little interesting. So, laptop screen ka full karo?
No, sir, full. Full.
এটাকে ফুল করে করা যায় না Well, when we started core biopsy 10 to 12 years before, there was a challenge because most of the prescription was FNA, and there was a challenge to convince the clinician as well as to the patient to convert it in the form of core biopsy. So we used to talk about changing concept in the field of core biopsy. There is a jump or shift from FNA to core biopsy, and the second changing concept was any lesion anywhere concept. Means when we were student in SSKM hospital, our professor just looking at us and it is very difficult. It is small. Nahi hoga. So we popularized this technique as any lesion anywhere concept. Be it in the central mediastinum or posterior mediastinum, be it in the anterior mediastinum, be it in the spine or vertebra. You have to have your modified technique and change your hardware, your technique, and your planning. You can actually biopsy or sample those lesions like here. There's a posterior mediastinal mass where a prone position with extrapleural approach has been taken care of to do the sampling. For anterior mediastinal mass, a parasternal approach with an oblique line, oblique angle, avoiding the this lima, left intramammary vessels, and for vertebral biopsy, the transpedicular route on prone position. So these are the modified techniques you can adopt to do a complex biopsy, a complex location. So our target is it should not just plan to get a good code. Your plan should be to avoid potential complications associated with. So at today's practice, any lesion anywhere concept does not confine within the planning of core biopsy or percutaneous biopsy. Sometimes you have to consider the transbronchial approach, endobronchial biopsy, TBNA, EUS, endoscopic ultrasound, sometimes transjugular TGLP for a transplanted liver lesion biopsy, etc., etc. So this is all about changing concept in the field of core biopsy, and we must consider to reduce or to avoid the potential complications associated with. So to reduce those complications, especially when we are dealing a complex lesion or difficult lesion, so these are the prima facie things we need to do before we plan, before we take the patient on the biopsy table. So a consultation in the clinic in the OPD is very important. We must look at the scan carefully and plan accordingly. The risk and benefit ratio need to be discussed. Means to consider a difficult location biopsy, how much risk we are going to take and how much benefit we are going to provide need to be discussed. We have to choose the appropriate modality. Sometimes ultrasound guidance is better, sometimes CT guidance is better, sometimes we do combine CT and ultrasound guidance that need to be planned. We must explain the potential complications. We should do some pre-operative investigations. And last but not least, informed consent with written documentation is very important to avoid legal issues as well. So let's just take a few examples. If there is a lesion in the liver at segment 6, it is very easy to pick up on ultrasound. So I prefer an ultrasound guidance rather than a CT guidance for a segment 6 lesion in the liver or a left lobe liver lesion. Similarly, for a neck node or neck mass, I would prefer ultrasound guidance rather than CT guidance to take a quick and easy biopsy. Whereas if there's a lesion like this at segment 8 or segment 7, high up in the liver, just below the diaphragm, here it is surrounded posteriorly by the lung air, anteriorly by the vessels, hepatic veins. So here ultrasound guidance is little difficult. I would prefer a CT guidance with an access like this, and I also want to inject small amount of, 50 ml of contrast to opacify the hepatic vein to avoid the middle hepatic vein injury. Similarly, if I have to plan a biopsy of this kind of renal lesion at its upper pole, which is indenting the liver capsule, I would prefer this lateral oblique route rather than transhepatic route at 12 o'clock position. That's the way I have to plan. So I would avoid a transhepatic route. I'll place the patient as lateral oblique position, and I'll prefer this route to take a safe and easy access. Whereas for a thigh lesion where I suspect a sarcoma, I would prefer an ultrasound guidance with a thick white cord using a 16G gun, biopsy gun. I talk about biopsy gun. So to get a good cord, and I use an ultrasound guidance here. And the trick to do a soft tissue sarcoma biopsy is a surgeon has to draw the incision line, and I have to take the biopsy along the incision line so that the biopsy tract, which is a potential site for the future recurrence, can be excised by the surgeon. That's the trick to do a soft tissue sarcoma biopsy. So we need to plan, and we need to consider all those small things to plan for a biopsy. Sometimes you need to consider whether the biopsy is really indicated or not, or whether we can avoid the biopsy or not. This is a patient visited us in my previous hospital, Aranthagar Hospital. So this is a cirrhotic liver, splenomegaly, arterial phase scan. There is an arterial phase enhancing nodule here in the left lobe. So the diagnosis cirrhotic liver, arterial phase enhancing nodule. So obviously the diagnosis is HCC. We are looking at HCC nodule. So when this patient was referred to us, we offered an ablation therapy, or left lobectomy or ablation is the standard therapeutic treatment. if the liver function is bad, then probably transplant, otherwise lobectomy or ablation is the treatment. But the patient relative was little pseudo-educated and argued for the biopsy. There is no biopsy proof, and you are arguing that this is a cancer, so we don't believe. And they go away, they visited multiple hospitals, big cancer hospitals, and ultimately after 8 or 9 months, they again came back because they got the similar suggestion or similar treatment in the other hospitals as well. So they came back after 8 to 9 months, and when we did a repeat scan, arterial phase scan, the lesion was previously it was 2 centimeter, now this is 3.5 to 4 centimeter. So you see, this delay had actually changed the treatment modality. So previously our plan was only to ablate the lesion, but now it is bigger and it is difficult to take over with only ablation. So we did a super selective test, take the control of this thing, vascular control, and after 6 weeks we did an ablation. This is a CT guided CT planning and combined CT and ultrasound, post ablation ultrasound appearance. So there is good ablation with fantastic margin, and that tumor was cured without any proof of biopsy. And more importantly, when surgeons they talk about R0 ablation, we talk about A0 ablation. It's same as R0 resection. We talk about A0 ablation. So before you consider complex biopsy, you must do some preoperative investigations. All are very important. The platelet count is important, INR is important, hepatitis ratio is important, and urine culture for prostate biopsy is important. There are some guidelines from British Thoracic Society, from Royal College of Radiologists, and NHS Trust. These are very important. INR should be less than 1.5. If it is more, we need to correct it either by vitamin K injection or transfusion plasma. Hepatitis ratio again should be less than 1.5. Platelet count should be more than 1 lakh. Very important. If there is dual antiplatelet, we need to stop the antiplatelet 3 to 5 days before we do the biopsy. If there is a stent in the coronary artery, so we have to convert the patient to short-acting heparin, stop heparin on the day of biopsy, and restart antiplatelet 24 hours after the biopsy if there is no bleeding. So these are the preoperative minor things you need to consider. Biopsy gun, this is a sponsored program by BART. So biopsy gun is important. I will take just 1 minute to talk about this biopsy gun. There are 2 types of biopsy gun. One is automatic and the other is semi-automatic. And there is a coaxial system, there is a non-coaxial system. So this gun is a non-coaxial gun. The advantage of coaxial gun is once you put the needle in, through this needle you can take multiple cord. You can take multiple cord, whatever you want, especially for lympho, you can 5 to 6 cord. So once you put in a needle in, and you take as much as cord, you take sample, you take as much as cord. You don't need to prick the same area again and again. But for non-coaxial gun, you have to prick again and again. That's the advantage. That's why this is little expensive. This is less expensive. Now, there is another type of gun, automatic and semi-automatic gun. I'll explain what are the advantages of semi-automatic gun. So this gun is automatic. Once you fire like a missile, it is gone. A semi-automatic gun, you place it like this. You're cutting through length, place it like this within the lesion. You take a CT cut. If you think that your tip is hitting some vessels or some important or intestine or some area, you can pull back a little, or you guard with your finger and you fire. So that's the advantage of semi-automatic gun. I'll show you some pictures and examples where we prefer semi-automatic gun and how safe this gun is. So semi-automatic biopsy gun. Say for example, I have to do a biopsy from a splenic tail lesion, from a splenic. The site of the splenic vessels. So if I use a 2 centimeter throw length cord and I do a missile-like fire with this, I will invariably fire or injure the splenic vessel. So here I use a semi-automatic gun with 1 centimeter throw length. Another advantage of this semi-automatic gun is, if you want to restrict your core by 1 centimeter, You can do it, you can take a 1 centimeter core, you can, if you want to take a 2 centimeter core, you can make it 2 centimeters. That's another advantage of semi-automatic. This is especially hard gun, this advantage is there. So, similarly for a paravertebral small lymph node which is close to the renal hilum, here is the duodenum. The same advantage, we use a semi-automatic gun and we will restrict our core into 1 centimeter to avoid duodenal injury or vascular injury. So, if we talk about thrust-guided biopsy for a prostate-confined tumor, the key is the NP-MRI. This is a picture from our machine, fantastic MRI machine. So there is a tumor here, diffusion restriction, ATC hypointense. And if somebody has to do the biopsy for prostate, we take 12 core from various areas, right side, left side, upper, middle, lower. So if you plan based on this MP-MRI, I can restrict my core into only 6 cores. That will reduce the chance of bleeding, that will reduce the chance of urethral injury. On top of that, we'll get a positive, the chance of getting a positive result is much more. So MP-MRI, DRE, PSA, and plan your biopsy will get a fantastic result with minimal complication. So when we talk about complex biopsies, those lesions can be categorized into small lesion size. That's a complex biopsy. When we target a 1.5 centimeter or 2 centimeter lesion, when there is no direct access and lesions in difficult location are the biopsy which are considered as complex biopsy because they are associated with higher risk of complications. So I'll take few examples. Say, for example, there is a lesion here. There's a lesion here, a small paravertebral node or retroperitoneal node. Here is the aorta, IVC, ureter, delayed scan. So the way I will plan, I will place the patient on prone position. This is paravertebral muscle, a psoas muscle. I come from back through the psoas muscle. Needle tip is here, ureter is here, aorta, IVC, duodenum is here. I take a 1 centimeter core, couple of core to make the procedure safe without any complications. So this biopsy was done in my previous hospital and this was turned out to be a tubercular node and accordingly ATD was started. So sometimes, in my previous hospital there was robotic arm. Robotic arm can precise the needle, can precisely press the needle, especially when the lesion is small. So for a small solitary pulmonary lesion, pulmonary nodule, somebody can use a robotic arm, but this sounds nice in the CME, but on practical life, the robotic arm, docking of robot, the planning and everything is very cumbersome and time consuming. So, but robot is very helpful for ablation, especially renal tumor ablation, the precise needle placement. So this is a very interesting case, pararenal small nodule. We did a biopsy. And there's a history behind it. This patient was a doctor's father. This kidney was already operated 2-3 years before. CKD3 with creatinine 1.8 was on regular follow-up. And the other kidney shows a small enhancing lesion with restricted diffusion. We suspected that was a RCC recurrence. Yes, RCC, the other kidney RCC. We ablated the lesion nicely, but at the end of the ablation, we found some sort of minor abnormality here, but that time we stopped everything and kept the patient on follow-up, and there was a minor small nodular recurrence here in the pararenal area, and that was biopsied, that was proven to be RCC, and we again ablated this area to get a cure. So next group where there is no direct access. So here is a lesion in the uncinate process of the pancreas. Now in the era of EUS, these biopsies are not difficult. The gastroenterologist will do the biopsy. But in our time, EUS was not so popular and facility was not available here, everywhere in many hospitals. So what we have to do water dissection or hydro dissection to shift this colon and other intestine from the way. And here we have to use a thinner gun, 20G gun, with a coaxial system to take a biopsy, but always it is not possible if the patient is lean and thin and too much of intestines is not there, and intestines, if they could be shifted with the hydro dissection, then only this kind of biopsies can be done. So transclinic route biopsy for a perisplenic lymph node or tail of the pancreas mass is an accepted technique, but the risk of bleeding is there. How do we tackle this transclinic biopsy, post-biopsy bleed? We inject gel foam slurry through the outer needle. We take the biopsy, keeping the outer needle there, we inject gel foam slurry through the needle to plug that tract to prevent post-biopsy bleeding. It is called plugged biopsy. Some people prefer to put in a coil in the spring coil, the metallic coil, to prevent bleeding from the biopsy tract. So this is called plugged biopsy. Transgastric route is not always should not be preferred nowadays in the era of EUS. Again, for the head of pancreas mass, you can do transgastric biopsy if the EUS facility is not available, but risk of gastric leakage is there. You have to use a thinner gun, and you need to keep the patient NPM 4 hours before and 4 hours after. The last one, difficult location biopsy. Portocaval lymph node like this. You have no route actually. Anteriorly there is no way. Posteriorly there is no way. Here is the IBC. Anteriorly there is a portal vein. So only route is transhepatic route, but there are hepatic veins. But if you place the patient on the gantry in a lateral oblique position like this, your access is little easy, and you can plan your biopsy with combined CT and ultrasound guidance like this to get a good score. So simple technique, simple positional modification will make your life much more comfortable. These are the simple tricks and tips I wanted to highlight as technique for complex biopsy. My talk will never be completed if I don't mention about the complications. So potential complications are bleeding complications. We had already discussed infection, chance is very less. We are a little scared about prostate biopsy related infection. Bowel injury already had discussed. Pneumothorax for lung biopsy, we all know it happens. Either you have to put in a needle or a drainage catheter and follow up the patient with water cell drainage for next 24 hours. Vascular injury is something for retroperitoneal mass biopsy, central lung biopsy need to be taken care of. Bladder injury for cross-guided prostate biopsy, we need to consider before we plan for complex biopsies. So take-home messages: appropriate planning and technique with properly chosen hardware and imaging modalities are the key to success. Positive samples should be obtained as high as 95% in cases of poor biopsy. Inadequate sample or inaccurate targeting are the most common cause of negative result. Complications might happen, though rarely, but we need to learn to manage complications immediately, aggressively, and very efficiently. Thank you very much for your time.
Thank you very much, Dr. Samui, for your presentation. Now I would like to invite Dr. Somen Das.
Yes. Dr. Rahul will present one case as because we are discussing hyperthermia.
Right.
So we will have one case of hyperthermia.
Okay.
Fantastic.
So, Dr. Rahul Agarwal, please.
One short introduction from Dr. Somen Das.
Okay, please.
This was a case. This was a case as we were discussing hyperthermia. Now see this as her, it was a very wonderful presentation. I saw your presentation very carefully. But you put everything in a blanket policy that you will have hyperthermia for all radiation, will have hyperthermia for all surgeries. There is a technical problem in surgeries. The surgeons will also got heated, you know. So the way we treat hyperthermia, we are using hyperthermia in the form of HIPEC. That's that's a standardized technique for peritoneal cancers, for mesothelioma, for pseudomyxoma peritonei, for mucinous tumors of appendix and colon. Today we will be discussing one such case where we used hyperthermia and it does have a PFS and OS benefit. Unlike the data which are not, I don't think there is very robust data on using hyperthermia along with radiation which will show a definite PFS or OS benefit. But this hyperthermia modality has definite data where we have an evidence, survival evidence. Okay, so now.
Good afternoon, everyone. Thank you for this opportunity to present this case. This case was done about a month back in our institute, and this case clearly shows what perseverance and patience can achieve. Now, this was a 43-year-old gentleman who presented to us with complaint of gradual distension of abdomen for past 1 year. And on examination, a lump was palpable in the epigastrium extending to from the right side to the left side of the abdomen, and there was separate mass in the left iliac fossa. Now, investigations revealed on colonoscopy there was just a mild bulge in the cecum, nothing in the intraluminal side. CT scan guided biopsy revealed that it's a lamin appendix. CA99 was 24.4, CA125 40, and CEA 10.1. All these are prognostic markers. Now, on the 14th of February, we did a procedure, cytoreductive surgery with HIPEC on this patient. As soon as we opened the abdomen, I'll share the pictures with you. There was diffuse disease starting from the diaphragm both side to the peritoneum. Not a single position in the abdomen was spared. It was disease everywhere. We did a complete peritronectomy with glycinectomy. The glycin's capsule of the liver was completely removed. Along with that, multiple organs, the spleen, gallbladder, the omentum, right colon, anterior section, sigmoid colon, everything was done, including stripping of the mesentery. Total duration of the procedure was 10 hours. We started with a PCI of 28. PCI is actually peritoneal carcinomatosis index. It gauges the extent of disease present in the abdomen. The highest score is 39, and 28 is, believe me, it's a very high score. And after 10 hours of hard work, we could achieve a CC0 score. CC0 is actually a score which indicates the extent of resection we were able to achieve, and CC0 indicates complete resection. Post-operative period was uneventful. Patient was discharged on POD 10, and the histopathology report is still awaited. Now, this was the picture what we started with. This was such a huge mass present in the abdomen as soon as we opened it. This was in the pelvis. This is in the left side paracolic gutter. And see, the clean abdomen we could achieve after almost 7 hours of surgery. Around 3 hours it took for us to closure and HIPEC and all. And after 7 hours, this is the clean abdomen what we achieved. Both sides of the diaphragm. This is the HIPEC machine which we currently use in our institute. We use oxaliplatin in this case, and a temperature was around 42 degrees centigrade. This is the HIPEC procedure what we are doing. This is a specimen. Here is the spleen, the omentum, gallbladder, the left colon, the right colon, along with the omentum. Now the evidence. What does the evidence say? Now in 2018, a Chicago consensus guidelines was issued, and which showed that the only treatment available for lamin appendix is CRS and HIPEC. No chemotherapy, no radiation, whether given preoperatively or postoperatively, will work on these patients. Only a well done CRS achieve the CC score can achieve a long-term survival. Similar guidelines were also given by SOGI. It is peritoneal surface oncology malignancy group. This was our team anesthesia. That is our surgery team. Thank you.
So, Dr. Rahul, I have one question. So ideally, when we talk about the PCI scores, and we usually, I have seen like discussing in MDTs and all, whenever the PCI scores tend to cross 23, 24, usually in ovaries and all, we don't consider doing a high take. So you say that when the disease is lamin, then in that case, even for higher PCI scores, this is quite a hypothetical situation, right?
In some malignancies like mesotheliomas, in PMPs and lamins, there is no other option other than doing a good CRS.
Right.
So whatever the score might be in PCI, we have to go in for the surgery. If we can achieve a CC0.
So in that case, do we really need to do a PCI in such cases? That is the question.
The issue is that we have to gauge where we started and where we landed up. That is more important, because we have a high PCI, we can counsel the patient that we have a PCI higher, there is a high chance that it can turn out to be inoperative. So it is very important to assess the PCI. Whether it is by radiological PCI or by its open mirror, that is a different issue. But PCI has to be assessed in each and every case. That is the
do we have any cutoff PCIs for this lamin?
Not for lamin, not for ovary, not for mesotheliomas. But stomach is for 6 and for colon is usually taken as 12.
Well,
So you see, this exact discussion happened in our surgical group. The day we operated, Rahul posted this thing in our group. The same question was asked, ki you are doing CRS HIPEC in a PCI of more than 20.
Yes.
This cutoff is not there for peritoneal cancers, primary peritoneal cancers and lamin and hamen. Because in these cases, pseudomyxoma peritonei, mesothelioma and lamin and hamen, the only option is CRS and HIPEC. In especially lamin, low grade, there is no option of going for chemotherapy and etc. So there, PCI is not a barrier, PCI cutoff mark is not a barrier, but the point you mentioned, ki, what is the importance of assessing PCI there? There are two issues. One is if I have a high PCI, I will have a suspicion that this might turn out to be an inoperable one. Especially when you have dense areas in the porta, or if you have digeflexion involvement, or if you have a long segment, short bowel involvement, small bowel involvement. That is the area where you don't operate. See, we removed almost 80% of the colon. The whole right colon was removed and anterior dissection was done. So 60-70% of colon we removed. That doesn't matter. But you cannot remove the whole of the small bowel. So that is a contraindication. But for ovary, even in ovary, 20-25 is doable. For colon, there is a strict criteria. For colon, if you search in colon, HIPEC in colon, the first thing will come up that it is contraindicated because of that PRODIGE 7 trial. But that trial was flawed, number one, because they used 60 minutes of oxaliplatin, but by and large, for colorectal cancers and stomach cancers, we use mitomycin C or cisplatin, and that to be used for 90 minutes. That's the standard recommendation. So that is why that trial is flawed and it is being criticized. Number two is, even in that setting, they found a good response in PCI between 8 to 15. So in colon, 8 to 15, not more than 15. So 15 is the cutoff for colon. Okay.
Thank you.
Thank you, Rahul. If anybody else has any other questions, you can please go ahead. Oh, sure.
But clinical evidence with evidence based on properly conducted clinical trials, maybe.
hyperthermia trials are there. There are two trials of hyperthermia which have been published in the Lancet, and none of the trials have actually shown that using hyperthermia before RT has translated into any form of survival advantage like be it PFS or be it OS advantage. So at this point of time in India only one center was running a hyperthermia protocol, that was Max Nanavati under Dr. Nagaraj. So that project has also stopped after the data has come out.
Hyperthermia does show a response, but they are not translated into a
The response is immediate response. Basically,
hyperthermia does show a response. That is true. That your data is perfectly correct. But the ultimately what patient wants is a clinical response. It makes a difference to my survival. It might increase resistance. That matters to the patient, and that is what is currently not seen with hyperthermia. Now the things have to do the laboratory into the actual field. That's the meaning.
Thank you very much, everybody, for participating. We come to the end of this seminar today. Thank you.
We will have it or we.
no, I think it,
Do we have time?
Kodum is not there right now.
Uh,
Madam, Kodum is patient खराब हो गया तो ऊपर चला गया ना ना patient तो पूरे तो ये admit करे
तुम्हें तो कल ओवर ही नहीं बोला, तुम्हें बोला. Don't make it a panel discussion, make it a day.
no, because it has been designed in the form of panel discussion, you can all take part in it.
Yes.
Okay. Oh, no. You can give a talk on that. And then other people
also
discuss.
discuss.
So thank you so much. Again, thank you. So thank you so much.
Thank you, Professor, and thank you, organizers, for having me for this particular panel discussion. So I designed it in the form of a panel discussion wherein we had Dr. Polomi as one of our, she is our medical oncologist. Then we have Dr. Shomen Das and Dr. Rahul from surgical oncology. We have Dr. Chinmay Basu, our gynec oncologist, and we have Dr. Parthosan, our radiation oncologist. So the main idea was to conduct this panel in this particular setting of stage ovary. So it was a case, and the case is not a hypothetical case, it's a real case. And this is my patient from last week. The patient is a 55-year-old female patient, E320, performance status of 1 with no family history of any malignancy, no comobs. She presented with bleeding PV, progressive and progressive abdominal distension. On PV, the cervix was healthy, no, and the bilateral para was free. Rectal mucosa was free, and all the blood parameters were within normal limits. Now the question is, the abdomen upon per abdominal examination, it actually showed like there is something, a palatable, huge palatable mass. So the thing is, next what do we do? Now, sir, if a patient of this case presents to you, and you do your clinical examinations, your parameters are all within normal limits. So, what exactly is your next plan of action, kind of?
We have not done yet ultrasonography and CA125.
Yes.
So those are the things that we are going to do. First, then maybe we will be doing a CT scan also.
Okay. So the thing is, now sir has mentioned CT scan. Now we usually talk about tumor markers. I have specifically mentioned serum CA125 because I was biased towards this panel discussion. We also do serum CEA. We also do, serum alpha-fetoprotein also to be very sure about how we are placed before we go into our imaging. And like now the question is that we have the option of CT scan, we have the option of a PET CT scan. So in first line setting at diagnosis, surgeons, any of you can take this question, would you prefer doing a CT or would you prefer doing a PET upfront? CT. So CT of abdomen or thorax abdominis kind of. Yes, absolutely. Because at the end of the day, whenever we are talking about abdominal malignancies, we should be very, very careful because PET has a very high chance of upstaging and falsely upstaging diseases. So in such cases, we should always consider doing a CT scan upfront, and until and unless the patient is very much symptomatic, we should not consider doing PET CT. Third point is, do you consider MRI to be as one of the staging modalities in this case? Would you as surgeons, like if you're planning a resection or something, you see the CT findings, in the CT you find the complex cystic soil or something, would at any point of time for your planning consider an MR of that tumor?
For staging of the disease, you don't need an MRI, but for two indications, probably when there is an indeterminate lesion in the liver, and second thing, when there is a local, stage 3 disease, particularly, it's a locally advanced disease in the pelvis, then probably to assess the rectum and do the MRI.
Exactly. So very rightly said. So the what happened was the CT whole of the pelvis showed it was a left ovarian complex cystic soil measuring 7 cross 7 centimeter with a small peritoneal deposit of 7 mm and by 1.2 centimeter. There was moderate ascites now, and CT thorax showed there was no mets, and the serum CA125 was more than 1000. So next, yeah, sir. Yeah, please. Sir.
We are talking about a complex ovarian mass, which is not yet biopsy. We talked about MRI. So in a cancer hospital, we always think about ovarian cancer, but there are some lesions, looks like a cancer on CT, like endometrioma, where the CA125 is also raised.
Not here at this spectrum. So endometrioma, the CA125 will be raised in around 1.5x the upper normal limit.
But sometimes endometrioma has been taken as ovarian cancer for surgery. So MRI is fantastic to differentiate between ovarian cancer and endometrioma.
Treatment, sir, I think will not make a difference because if it again translates to clinical evidence.
Yes, surgery, it is treatment is surgery, but there is role of medical treatment before surgery, and surgery is not radical.
So in this case, now that we have the CT finding, so surgeons now.
We will go for paralysis. I mean, ascites fluid.
Ascitic fluid, so it was a moderate ascites. The ascites, it was not a gross ascites that we would have gone it. So the thing is that in an ovarian disease where the patient is presenting with an ascites, we would still consider it as a loco-regional disease. It's not yet metastatic at this point of time. So which is where I would always have the surgeon's opinion The surgeons now, would you, very important, do an FNA or you would straight away plan the patient for an upfront surgery? Now, this is very, very important because, what happens is the patient is not having an ascites, doing an FNA sometimes ruptures the capsule and you tend to upstage the disease, is not it? So, in such cases, now the ascites is already there. So would you still consider doing an upfront FNA as a proof of malignancy before going ahead with CRS, or you would upfront go for a CRS? Any of you can take this question.
Well, if the lesion is there, it's operable on CT scan, and if there is no ascites, minimal ascites will do. But
It's a moderate ascites.
in this case, I will do a biopsy and NSC. With ascites, I will not operate the patient.
You will not operate the patient. What about you, Sumanda?
See, the question is whether you can take it out or not.
Yes,
If you can take it out, take it out. Don't
absolutely.
go for biopsy. But if, see, this ascites can be a nutritional or this moderate is a dicey part. If it is minimum, that's fine. If it is huge, that is also contraindication.
Yeah.
But if you can take it out, we can go ahead with upfront surgery. But if you have a minimum doubt that there might be a positive ascites, then you do a biopsy and go for NCRI.
I would once again go back to the imaging findings.
Why not FNS? It could be, explained by very low sensitivity of an FNS.
Sir, the thing is that is what he has said. I mean, the ascites, we are not sure whether it's a transudate or an exudate, number one. If it's a transudate and we do an FNA, we rupture the cyst, we rupture the capsule, and a stage 1 disease becomes a stage 3 disease in that case. So, in that case, a case wherein they could have avoided chemotherapy, now chemotherapy becomes mandatory. So, this is why we are not choosing to go ahead with this. Now, as Dr. Rahul has said, as the disease is already, there is a CA 125. CA 125, exactly. So that's
Possibly that's a metastatic one.
possibly, yeah.
So, Dr. Nupam,
Yeah.
can we go for the psychology of the SAP fluid?
We did a cytology of the ascitic fluid and
That can give us a
yes, its cytology and cell block came out to be negative for malignancy. That was the problem. Okay, because at one point of time we need to understand we need at least 500 ml of fluid for to centrifuge and the cell block to be prepared. That is very, very important. Minimal ascitic fluid, even in the tune of 200 ml, is not enough for you to get this thing out of it. So this is very, very important. Absolutely. So that is what has happened. So if, say for example, we choose the patient for a CRS. So would you combine CRS or with HIPEC, or you would do CRS upfront? And Rahul, my question is to you specifically, if you are combining HIPEC upfront, who is an ideal candidate in such cases? Let's for instant take it like assume that the patient is affordable for everything.
For this eligibility criteria, I can divide into two parts. First is fitness.
Right.
Patient has to be fit.
PS1.
PS1,
Yeah.
PS0, PS1 has to be there, and all the parameters should be okay. Like albumin, hemoglobin.
No comorbidities. Blood parameters always normal.
Diabetes hypertension can be taken, but has to be controlled comorbidity.
Right.
Other than that, from surgical disease perspective, a stage 3 disease nobody is a candidate who is always in a green zone. He or she is a patient that always goes in for a high.
Right.
There are some studies in stage 2B disease and very few select stage 4 diseases where you can get the organ removed, probably a very small segment of liver, you can take it out. But mostly stage 3 diseases are taken for high patient.
Fair enough. So Shomenda, would you like to add anything in this?
No, that's fine, because the trial which was published in NCRI in 2020, I think, that also says the same.
Absolutely.
So stage 3 onwards, you can go for upfront HIPEC, but one point, in that case, I might do a frozen of the thing which I remove, then only I will go for
Yes,
it.
it's
Right.
very important.
So what would you?
CRS we have to, HIPEC we have to do a process.
Right.
That's important.
Okay.
Before CRS, will there be any competition between NACT and CRS?
NACT is an NACP.
Yes.
NACP. Sir, as we have said, the thing is that if this decision is particularly taken by a surgeon. Now, if the surgeon is very, very skillful and he is confident about his skills and he is very sure after all imaging modality that I can do an optimum cytoreduction on this, then we would always say that the patient should go for a CRS. Hypec or not is a different question, sir, later on.
That's okay.
So,
I mean,
because
what
at the
is
end of the
proof for
day,
that? What is the proof for that? That CRS and not NAC will be giving us benefits. Is there any study?
120% study is there, sir. The study is that I would like to mention, I think it is GOG 121 study. If I am not wrong, the numbering, it's a gynec-oncology group study, which has said CRS, if feasible, should be attempted because an optimally cytoreduced ovary is as good as a not unoperated ovary. So, ovary, rectum, breast, the definitive treatment is surgery. We should not delay surgery at any point of time. We should not delay definitive treatment at any point of time. NSCT, yes, that will only help to cytoreduce the tumor, the disease, to reduce the disease bulk. Sometimes what happens is there is the tumor might be adhered to the gut, wherein the surgeon might not get planes properly. If he feels that the cytoreduction would end up in huge amount of bowel loss, in such cases, it is always better to go ahead with an NSCT. But having said that, based on the CT findings, if the surgeon feels that the disease will come up with a very, very good outcome at the end of the day and less morbidity, then it is worthwhile we go for a surgery upfront than NSCT.
So for advanced cancer, what is the optimal cytoreduction rate when you attempt surgery in the first place?
See, if I feel inoperable, then I will not go for surgery.
Absolutely.
No, amongst those you feel, this is just an experience
Yes,
that I'm
yes.
trying to understand. Like what will be, 50% cases you can you see that when you are thinking with all the evidences.
Almost 80-90% we are able to achieve adequate cytoreduction.
Optimal.
50% is very less.
I was remember one case in last 1 to 2 years where we attempted surgery and we could not achieve a
Optimal.
Exactly. Because at least in ovary or rectum or any peritoneal surface surgery, I don't think that they have opened and they have closed it. They did it very well. So, having said that, as Rahul has rightly mentioned, the ideal candidate for Hypec in this setting, so the patient actually underwent an upfront CRS. Now, after this CRS, the HPR came out to be a high-grade serous ovarian carcinoma. The ovarian tumor had already breached the capsule. The omentum was, the node that was there in the omental nodule was positive for malignancy. Ascites now this time, the peritoneal washings became positive for malignancy. The patient is still a PS5. Now, Partho, I will go next to you. Now you have the histopath with the surgeon has done his job. Now this is a 3C disease. Okay. So what is your plan? You would definitely put the patient on some kind of an adjuvant chemo, right? So these are your chemo options. You go for a taxane platinum combination. You can go for a triplet with taxane platinum bev or a taxane platinum bev followed by bev maintenance. I'll go to the fourth point, but let me come to the first three. What would be your choice of treatment?
If you talk about theoretical differential, third point is the best, but
Yeah.
it also depends on the availability.
Yes.
And also we have to discuss that in 3C, if we think it is a curative disease, but most of the 3C is not curable, I think one point of time theoretically decided, so what will be the option for that time?
No, 3Cs, it's not a 4 disease at the end of the day.
But
Yeah.
the cure rate beyond stage 1 is almost 0 in the ovarian cancer, basically ovarian cancer. So that thing also we have to keep in mind. So yeah, if you theoretically discuss hard option is the best. And also we have to discuss all the pros and cons when you are discussing.
So you're talking of the triplet followed by wave maintenance, right? So that is what was seen in the GOG-218 study. So this GOG-218 study in adjuvant setting first line. It was a randomized study which compared paclitaxel versus paclitaxel bev followed by bev maintenance for 15 cycles, and they found that the progression-free survival, and I'm talking this time about only progression-free survival, was significantly higher in the paclitaxel bev maintenance arm, and of course this did not translate into overall survival rather. So the advantage adding bevacizumab in first line adjuvant with maintenance was only in the form of PFS advantage and not OS advantage. So I would not go into subset analysis. Then again, we have another trial, the ICON 7 study, and as per the 2020 updated EFS and OS, we found that it again significantly was improving the PFS, but there was no real advantage of overall survival adding bevacizumab in adjuvant setting. And the CT thorax abdominal was within normal limits. So after a DFI of 16 months, disease-free interval of 16 months, she now comes with a serum CA125 of 29, but she is completely asymptomatic. It was a routine visit last week, and the CA125 came out as 29. It is still within normal limit. Now we have to understand the nadir level was 7.23. Now it is 4 times the nadir level, though within normal limits. So at this point of time, Dr. Das, would you consider doing any imaging for this patient, or would you still like to put the patient on a follow-up?
Since it is increasing.
Yes, it is showing an increasing trend.
Yes. I do a median ultrasound will do initially, but
Okay, CT. I did a CT tag for this patient, and it showed an isolated orbital deposit measuring 1.5 cross 1.5 centimeter. Now at this point of time, would you consider doing an FLN for this case? Because it's now after a DFI of 16 months, it's platinum sensitive. Okay, it has come out, the CA125 level is 4 times the nadir level. So would you consider doing an FNA, or would you, or maybe I can get back to you?
Yes, so what is my thing that patient is still completely asymptomatic.
Completely asymptomatic.
So I think for me the option is two. I think you can give the option to the patient to close follow-up, which is monthly C125.
But this CT finding was not
there
there.
is CT findings, that's why I'm telling that. So whether if the patient is asymptomatic, because we know there is a stage 3C disease which is going to relapse, and there is no data which is showing that these asymptomatic patients, they were on rising CA125, we start the chemotherapy and we delay the chemotherapy when the patient is symptomatic. There is no difference in the outcome, long-term outcome. So for me, I would like to keep the patient in very close follow-up.
You like to prefer a follow-up, and you?
why don't I dig it out?
Absolutely. So that we can always.
Because the ovary, the studies have shown that for each centimeter of disease removed, it translates to survival benefit. I would never
Absolutely.
want to keep the disease in the body. It's better to
Absolutely.
have a look and take it apart.
We did an FLA for this. Okay, it came out to be a malignant deposit, and within a span of 48 hours, the CA125 now rose to 59. Okay, so see, the thing is that there is also called an iatrogenic insult to a disease. Okay, whenever we are doing any form of procedure on a particular disease, the disease also reacts. It has its tendency to react to that iatrogenic procedure. So the CA125 right now was 59. So I guess there was no point observing this patient because the deposit was a malignant deposit at this point of time. And so now the question again, as a clinician, patho, now the patient, there are no metastasis, it is a single focal recurrence. Would you like to start off with your chemo, or would you like to send the patient to surgical colleagues? Surgical colleagues.
But I would like to know that what is the advantage of doing second loop CRS, and what is the survival advantage of PFS?
See, if we start thinking about advantage at each stage of recurrence, then we are left with only two options: whether we treat the patient or we don't treat the patient, right? Because
Exactly, so it is a point of view that we have to treat the patient at the right moment.
right, absolutely.
We should not treat the treat the patient.
Okay.
Ovary, there is a multiple line of treatment. They are going to know.
So is second look surgery an over treatment in this case? So
Actually, in these cases, first of all, hyping has got low.
Hmm.
What you have to understand, hydroreduction does not mean that always we have to take out everything what is in the abdomen.
right, the patient did not undergo hypec upfront.
Yeah, that's fine, that's fine, that is fine.
So
The whole idea is there should be no visible disease first.
fair enough.
When I enter the abdomen, whenever there is a disease, I am taking out. Just because there is multiple patches of disease, we do not total penetrative. First, I have to be clear. Second, when we go inside the abdomen, it is does that 1.5 centimeter disease, we are able to see the CT scan. Patches of disease which are there on table, we have to decide what are the things we have to remove.
Understood.
But complete hydroreduction should be.
Say for example, Shomenda, you are doing a hypec in this case. What would be your drug of choice as the chemo agent?
I will go for systemic.
So you will use a platinum in this case, yes. Fair enough. So we are using platinum, And I guess mitomycin has got very, very limited role in this setting. So it has to be re-challenged with platinum at any point of time, be it high-tech, be it systemic therapy. So the patient actually, now this is where the hypothetical part starts. It was till last week, so this has not been done. So I have just to, for the sake of this discussion, the patient underwent a CRS plus high-tech. And the omental nodule that came out in the specimen was a high-grade ovarian neoplasm. Now, this I wanted this question for Polomy to be answered. So, if this comes out as a particular, AGON, would you need any further added information on this, or would you start your treatment based on this?
Yeah, it depends on the affordability of the patient, because what are the lines?
I told upfront patient is affordable for everything. Is a millionaire.
No, but patient could not afford the reversible first.
No, that's what I'm trying to say. So, if we have coupons, 8,500 rupees, sir. Okay.
There was a crash in stock exchange, so.
Would you like to do any molecular tests? If yes, what?
So we look for the, let's say, one sample.
Yes.
HRD.
Yes, exactly. That's what.
It's not the,
So the present recommendation is we do a BRCA mutation status, BRCA wild or BRCA mutant, both 1 and 2. We do both germline as well as somatic, and germline is done by the blood sample, somatic is done from the tissue sample, the paraffin blocks. We also have the option of doing an HRR somatic. So this is the homologous recombinant genes that are, another NGS that we do along with the other minor gene mutations, which might be present in 12% of cases other than the BRCA ones. So this is what we usually do. And the patient came out to be a BRCA wild. So it was not a mutant BRCA. So in BRCA wild, so the options right now, again, if any of you can take this question, you have, now it's a platinum sensitive recurrence. So you have again taxane platinum, then the triplet and followed by BEV maintenance. You have GEM carbo, BEV and BEV maintenance. You have lipodox carbo, lipodox BEV maintenance. Or would you like to right now incorporate PARP inhibitors at this point of time? Any idea?
Just before this thing, there is a trial, we are a part of that also. Washington has started this trial of giving, adding rucaparib in hype.
Rucaparib in hype. Okay.
So the drug is rucaparib. You are delivering it.
Right.
I will get to submit it to EC and subject it to get approval. But irrespective of BRCA.
Okay.
So that's a trial.
So I think the trial is actually,
during the hype.
During the hype.
So,
mixing the rucaparib. Yes.
so Shubhendra,
Rucaparib was her research product.
Yes.
so the reason for that is
She
it's
approached.
no, the reason is quite it's quite I can understand the reason because first of all, if we talk about PARP inhibitors, the first PARP inhibitor that got FDA approval was olaparib based on the Paula study, which mainly looked into the BRCA mutant cases. And the advantage, it translated into both PFS and OS advantage, adding olaparib. Rucaparib came into picture with the Athena mono data. Now, Athena mono data, they say that in rucaparib, irrespective of BRCA status, if it's a platinum sensitive, you put PARP inhibitor as maintenance for an optimum period of 24 months. Because in first recurrence, the PFS has been found to be maximum 24 months. So you add rucaparib along with bevacizumab for a period of 24 months, and that is where you can have your optimum survival advantage. Anything less than 24 months is not going to impact your survival.
So monotherapy?
No, along with bev maintenance. You cannot give monotherapy.
Niraparib will be monotherapy. Niraparib is recently approved. But it will be monotherapy and single therapy.
Not available in India, I guess, at this point.
What is Dr. Omiko is trying to say, the BRCA wild also can be going, because it is the data with the
Already without BRCA, you can.
Yes. So this is what we were talking about in platinum sensitive case, adding bevacizumab, Ocean's data. Now Ocean study, this was, GEM carbo bev versus placebo plus chemotherapy, and it said that, adding bevacizumab as first line in platinum sensitive cases was significantly benefiting the PFS and there was again no advantage of OS. However, the Aurelia study in platinum resistant cases had shown some benefit in OS, but that was the numerical benefit, not statistical benefit. The GOG 213 study again in platinum sensitive setting showed that adding bevacizumab to taxanes was improving the PFS but not the OS. So at any given point of time, if any medical oncologist is asked why are you so much pro for bevacizumab, the answer is it's only PFS. The benefit is only PFS. It is not translating into overall survival. So this is I have compiled the entire set of settings of bevacizumab. In first line GOG 218, the benefit is only PFS, no OS benefit. Icon 7, add bevacizumab, only PFS, not OS. Oceans data, only PFS, not OS. GOG 213, Aurelia, whatever be the setting of ovarian cancer, bevacizumab does not translate into overall survival advantage. As simple as that. PFS, yes, OS, no. And lastly, for the olaparib, I was talking about the Paula study. So olaparib along with Bev maintenance as first line maintenance in ovarian cancer, the Paula data has also shown that there is significant OS as well as PFS advantage. And with this, I would like to thank you for your active participation. Thank you so much.
If anybody has any questions regarding this discussion, you may go ahead. I don't think there is. Thank you very much. Thank you all the panelists.
We have got enough.
You have enough, yes. I agree to that. What?
Can we offer just 5 minutes of time to the sponsor and BART? Anybody from BART want to say?
Yeah, sure. If anybody wants to say
Just 5
anything.
minutes. 5 minutes for you to that.
Dr. Soumya has already shown the biopsy, two biopsy and one is one transport and second is vision. Let me show you one more biopsy. This is the biopsy and basically the size is for breast biopsy. This is for breast biopsy. This is the marking. Basically it's automatic and both semi-automatic. Both the things are there. Most important thing is that it's a very lightweight biopsy. Second thing is that when you take the sample size is more better than the mission and the mass one. This is the difference of this biopsy. And one more thing I have to show a pleural effuser. This is the pleural. Basically, SITs are for in pleural effuser. Basically, doctors are using our pigtails, tapping is there. We are happy with pleural effuser. There are 30 fenestrations and the thing is both inside we have to make two gaps here. Now from one gap insert this enter the pleural cavity and this will stay in the middle of the two separate tests and it will be out. This is the catheter of silicone based catheter, a very soft catheter and it is a one-way valve. Cannot be only come outside. The fluid will only come outside, not come inside. Second thing is that we have to connect this.
Just take an introduction and if there is a recurrent frequent pleural effusion requires frequent admission, recurrent malignant pleural effusion requires frequent admission for drainage. This is a not permanent solution for a longer relief. So it is a tunnel catheter. There will be a tunnel. So keeping a pigtail without a tunnel increases higher risk of placental infection. So this is a tunnel catheter with a drug coated valve there, drug coated valve. It is drug coated, it prevents ascending infection. So we can keep this catheter in the pleura for 2 to 3 months?
No, sir, more than 1 year.
More than
More
1
than 1 year. And we have seen autofluorosis has been happening within 6 to 7 months. 60 to 70%. And it will go inside.
There is one thing, this drug is to prevent the infection or for chlorosis?
For infection, second infection, it's an infection. And through this, the fluid will be deposited. Even somehow the patients are very, they do not have a so much of money. For that, we are also having this type of catheter where you can put it here, lock it, and use it most important thing is within 6 to 7 months, autofluorosis will happen, and there is a less than 1% chances of infection. If the yes, 6 to 7 months, we have 6 to 7 months. Yes. And the patient have
Out of 100, how many patients?
sir, actually, Dr. Dayanand has put regularly this thing in Tata Medical. And he has achieved around 60 to 70% patient who have achieved the fluorosis within 5 to 6 months.
And none of the single case of infection.
No, only 1%, sir. Actually, the patient who are using this product in their home, they are not using sterilized. That is the main problem.
So it is not possible to audit.
No, that is the, actually, for that we are giving this thing, and even,
This means that it is difficult for the family member to.
no, we educate them. You see, today also, I am going to their home, and we will going to educate them. He told me that 2 to 3 times we have to come, we have to educate. Okay, no problem. I will
My lord saying that it is going to stay at around 1 year. It is difficult for all of
It's
the.
upon the patient.
Yeah, definitely 100%.
How will it be?
Difficult, right?
Last time, one patient has been in jail here. He don't know how to do. I went there, I seen that they started itching. And for that, full infection. So I told him to just rub it, put it in, and everything he had done. And that how it is.
Okay, thank you very much. The same thing can be used for recurrent ascites. Same thing. Yes, recurrent ascites. And for ascites, one more advantage is there is no risk of remorse. The ascites you just keep it here. So like urination, you just open it and it drains some ascites. For CHD with recurrent ascites, recurrent malignous ascites, same thing.
Sir, one thing I have to request that you can only use this thing. No